Welcome everybody to the third and final webinar in the American Diabetes Association webinar series. We are celebrating ADA Research Week. We are honored to be part of this. Our Chief Medical Officer, Dr. Leon Eagle, is being awarded as the Medical Honoree of the Year. And Dr. Aronne has graciously agreed to give a talk today about diabetes and obesity. So I'm Dr. Katherine Saunders. I'm an obesity medicine physician on faculty at Weill Cornell and a co-founder of IntelliHealth. This is Dr. Louis Aronne. I'm thrilled to introduce the one and only Dr. Louis Aronne. 40 years before anybody was talking about obesity or Ozempic, Dr. Aronne was actually a fellow in the medical intensive care unit at Weill Cornell at New York Presbyterian Hospital, where he noticed that patients with excess weight had many more comorbidities, that they had longer hospital stays, and they had larger hospital bills. And he knew at this time that excess weight was about so much more than just eating too much, exercising too little, and really suspected that there was something else going on. So at this point, he decided to devote his career to really understanding the biology of obesity, the disease of obesity, and developing effective medical treatment protocols for obesity. So Dr. Aronne went on to be the principal investigator on over 60, is it 65, Dr. Aronne? 65,
Something like
65-ish, yeah. Randomized controlled trials of what now are the anti-obesity medications. He also edited the National Institutes of Health practical guide to the identification, evaluation, and treatment of overweight and obesity in adults. So these were the first, set of guidelines many years ago. He also founded the American Board of Obesity Medicine with a group of physicians, and he served as the president of the Obesity Society. He's also won many, many awards for teaching and his tremendous contributions to the field of obesity medicine. Dr. Aronne is a true pioneer, and his dedication and perseverance are, really, one of the reasons why the field is where it is today. I'm privileged to have learned everything that I know about obesity from Dr. Aronne, and I can't wait for all of you to hear his wisdom about obesity and diabetes. Before I turn it over to Dr. Aronne, there is a Q&A section here, so please, as you're listening to him speak, feel free to answer questions into the Q&A, and if we have time at the end, we will hopefully get to at least a couple of questions. So Dr. Aronne, take it away.
Thank you very much, Katherine. And it's really a pleasure and an honor to be here with you all today. Is the presentation coming up there? Hold on a sec.
If you just hit that, yep.
Okay.
Good.
It's good? Okay. So Katherine, thank you so much. Leon, thank you so much. I've known Katherine since residency, since she was a resident. I've known Leon since he was in college. And really, they and a number of our other doctors, Dr. Rekha Kumar and others, have been instrumental in the development of this field. It's been very, very exciting to see how things have now evolved, because we were saying these things years ago. And I'm going to show you an example of one of them where over a dozen years ago, we were talking about weight-centric management of diabetes. Nobody was talking about that. And now it has become the standard of care. So I want to offer my congratulations to Dr. Eagle, and I'm looking forward to being involved in the events of the next few days. So here are my disclosures. So a lot of people, have obesity, but one of the major complications is type 2 diabetes. And it's been estimated that 1 in 3 Americans born in the year 2000 will ultimately develop diabetes in their lifetime. I mean, that is staggering. That's a staggering number. So when we look at it, why is this? And in my opinion, and I think the opinions of a lot of people, it's related to the epidemic of obesity that we have. And the percentage of the population with obesity has been increasing dramatically, not only in the United States, but worldwide. When we look at the numbers, they go from, in the United States, 15% or so in 1970s to by 2030 in the mid 40% percent. So that tells us a couple of things. Number one, my entire career is a failure because I've been treating obesity since the 1980s, and I obviously haven't been able to do very much about it. I did the first trial that I performed of an anti-obesity medication in 1989. So it's taken about 35 years to get to this point. But, I think it was worth it. When I see patients, I'm seeing patients all day. That's why I have my white coat on. And seeing the gratitude of patients who we are treating for their obesity with our new highly effective medicines is very exciting. It reminds me of why I went into medicine and why many of you physicians who are watching went into medicine, because we're doing something for people that makes them feel so much better. It's almost like a miracle. It's very, very exciting. And when we look at obesity and its relationship to type 2 diabetes, I always ask myself, why aren't we being more aggressive in trying to manage this? Why are we not getting anywhere? And the answer has been we haven't had effective treatments, really effective treatments. Treatments we've had, people were like, yeah, it's okay, I'm not sure. But now we have things that really, really work. And I think we're in the middle of a massive change in the way we look at the treatment of obesity and type 2 diabetes. And part of the reason is that the relationship between body mass index and the risk of diabetes has never been clearer. This is data from the Nurses' Health Study a number of years ago and other large scale trials looking at body mass index versus the risk of developing type 2 diabetes. And you can see that from baseline in the BMI less than 25 range, the relationship increases many, many fold. So the numbers you see here, so for BMI 35 and above, you see for women, it's 93. That means they're 93 times as likely, 93 times, that's 9,300% increased risk of developing type 2 diabetes if you're a woman and your BMI is 35 and above versus your BMI being in the lowest range, which is BMI less than 22. And for men, 42 times, 4,200% increase risk of developing it compared to a BMI below 25. I mean, those are huge numbers. And that's why we're seeing an epidemic of type 2 diabetes closely following the epidemic of obesity. Here's some data from the National Health and Nutrition Exercise Survey showing the epidemic of obesity evolving from 1994 to 2015. And right behind it, you can see the epidemic of type 2 diabetes blossoming in the population, of course, at a lower level of prevalence than obesity, but happening nonetheless. So what's causing this? And I'm going to talk for a little while about what is causing the epidemic and why we have it. But the bottom line is that highly processed foods, a poor diet, a lack of exercise, and many, many other factors, air conditioning, for example, may all contribute to the increased prevalence of obesity. And the problem is that this is adding a lot to our healthcare costs. So it's been estimated that for cardiovascular disease, 351 billion annually in healthcare spending and lost productivity. For diabetes, 327 billion. And obesity is estimated at $1.72 trillion, about 9% of the gross domestic product is affected by obesity. So it's costing us a lot in many different spheres. So the thing that we have learned over the last years about obesity is that it causes disease in many, many systems. So from the lungs to fatty liver disease, obesity is the leading cause of fatty liver and the need for a liver transplant. While we don't say that it doesn't maybe cause diabetes in everybody, it clearly exacerbates and worsens diabetes in the vast majority of people who have it. And what we're learning is that even people with low levels of obesity, for example, Southern Asians, they don't need to gain very much in order to develop type 2 diabetes. And we're beginning to understand why that is. There are 13 cancers related to obesity. Reproductive abnormalities, it's the leading cause of polycystic ovarian syndrome and forms of infertility. And the list goes on and on. So how does obesity cause all these diseases? When I first started, we did not understand this slide, that an increase in fat produces many hormones and suppression of other hormones, and that the net effect is an increase in inflammation and many, many diseases that we spend a lot of our time treating in medicine. So, for example, you need these hormones. They are critical for the normal functioning of the body. Like to maintain your blood pressure, you need angiotensinogen. To fight off infection, you need interleukin-6 and TNF-alpha. But when these are present in excess, they lead to the many different diseases that we associate with obesity. And that's been one of the most interesting parts of the story, is trying to fit together this puzzle of how, cancer is a very complicated disease. How could cancer be related to an increase in lipid stores? It's because fat cells are making many, many hormones, dozens of hormones. And again, when they're all produced in excess, we wind up having very potent stimulation of disease-causing entities. Now, there are mechanistic ways to understand this. I'm not going to spend a lot of time on it, but again, the point is that it is a multi-pronged attack. So here in this slide, Mathis Bluer and his colleagues were trying to describe how adipose tissue inflammation leads to insulin resistance. Many people think of insulin resistance now as a protective mechanism. Your body's pumping out too much insulin, and your cells are trying to protect themselves from the excess effect of insulin. And what that is doing is leading to what some people have called lipotoxicity, glucotoxicity. As fat cells expand, adiponectin levels are reduced. That has a pro-inflammatory effect. Leptin levels, one of the key hormones, actually the first adipocyte hormone, that increases inflammation levels. And then there are a whole bunch of pro-inflammatory hormones that all lead to impaired insulin signaling in target tissues and activation of these pro-inflammatory pathways that leads to insulin resistance. So the idea is that high levels of insulin promote the storage of calories as fat. As a result, fat cells expand, all of these hormones are released, and that leads to insulin resistance because your body's trying to protect the cells from the effect of all the insulin, and that leads to a vicious cycle of more weight gain, higher levels of insulin, and damage to the key organs. Now, one of the most important things to know is that obesity is something physical. Everyone looks at it and says, oh, that person's just eating too much. Why don't they just stop? And the answer is that by eating fattening food here on the left, the environment, that it actually makes people feel less full and have an interest in more food. And the way that happens is that high calorie, highly processed foods damage critical parts of the brain. These parts of the brain are in the hypothalamus, where body weight is regulated. The nerves get damaged by calorie excess. That leads to the storage of more and more calories. That leads to the release of pro-inflammatory hormones. This triggers inflammation and scarring in this key part of the brain, the hypothalamus. And as a result, the brain becomes resistant to the hormones that regulate body weight. So your brain can't tell how much you've eaten and how much fat is stored. And as a result, you keep trying to eat more and store more calories. So when we think about someone with obesity, the disease they have is hypothalamic resistance to the hormones that regulate body weight. And these include many of the drugs that are now being studied for weight loss. So here's a little cartoon showing the hypothalamus and fattening food. So normally what should happen is you eat food and it produces signals in the intestine like GLP-1, GIP, PYY. They go to the hypothalamus. They tell your brain how much you've eaten. Your fat cells send out a signal of leptin. Your pancreas sends out insulin. And so your body knows just what's happening, and it sends out hormonal signals, how much to eat and how many calories to burn. And what happens is that over time, the nerves in this area get damaged so that communication between food intake, energy expenditure, and what actually is going on is lost. So that the neuronal response to the inputs is damaged. And that predisposes to increased energy balance and also an increased production of blood sugar. So the effect here on the right in the liver is that your liver starts making more blood sugar. And that's where the diabetes part begins. So your plasma glucose increases when your liver starts producing more sugar. And what does that do? That produces more insulin, and higher levels of insulin produce more fat. That produces more inflammation. That damages the nerves, and it keeps going round and round in a vicious cycle. So that's how these are actually related. I mean, it's far more complicated, but I think this is helpful. And for a long time, diabetologists focused on managing glucose alone. And the paradigm was, does not matter what the patient weighs, give them all the insulin or other drug to control blood sugar. Even if the patient gains weight, it's okay. These are results of a famous trial, the Accord trial, which was published a number of years ago now, 16 years ago. And in this trial, those patients who were randomized to intensive treatment were getting insulin multiple times a day. With each meal, they were getting basal insulin, and the point was to treat their glucose as tightly as possible. And that was compared to standard basal insulin with boluses if necessary, and the use of other medicines that did not include as much insulin. So the people in the standard arm had worse control of their blood sugar, worse control of blood sugar. And one of the important findings was that those in the intensive arm had significant weight gain from taking the insulin, very significant weight gain. Whereas the standard group did not gain much weight, but they had worse control of their blood sugar. Perhaps the most important finding was that the hypothesis that tight control of blood sugar would be better and would prevent people from dying turned out to be wrong, because tight control of glucose actually seemed to increase overall mortality. There were groups that benefited, but overall, there was an increase in mortality. And this broke the glucose-centric paradigm of type 2 diabetes. It was clear that there was something else going on in the background that was affecting mortality. And I would argue that what we now know is that that was increased weight gain. So by giving a lot of insulin, controlling blood sugar tightly, more fat was produced, and that increased mortality. And we now have trials of some of our new highly effective GLP-1, and in this case, this is tirzepatide, a GLP-1 GIP dual agonist, and in addition to controlling glucose, which we know these new drugs like semaglutide and tirzepatide do, we also get fantastic weight loss. And in this trial, the SURPASS-4 trial, where tirzepatide was compared to insulin glargine over 2 years, you can see that the tight control with insulin group gained 2.3% of their body weight. Those in the higher dose tirzepatide groups lost 10, 11%, so a 13% mean difference in weight, in body weight. And in my opinion, we are going to see that this kind of change is really important. I'm going to come back to this a little later on to talk about what these changes mean. But the bottom line is we know that these drugs in people with type 2 diabetes, not specifically tirzepatide, but semaglutide and some of the other GLP-1s, have shown health benefit, significant health benefit. Part of it may be the compound alone, the GLP-1 compound alone. Part of it, though, I believe, is the weight loss. One of the other important findings of the past 10 years is that there's a dose response to weight loss. It was very confusing way back when, because we'd see that in one trial, there was health benefit in one area, then in another trial, there was health benefit in a different area, but then the next trial failed. How could this be? One of the things we've seen again and again is that bariatric surgery works great. Bariatric surgery tends to improve all of these complications of obesity. And the reason we now know is because it produces enough weight loss to benefit all of these areas. And so our new goal is 15% or greater weight loss. There may be benefits over and above 15%. That is true. But if you get to 15%, you'll see significant improvement in all of the complications that we see here. So at the low end, you can see benefits in blood sugar and blood pressure with even less than a 5% weight loss. It takes 5 to 10% to see prevention of diabetes, fatty liver disease, lipid disorders, and polycystic ovarian syndrome. To get some of the bigger illnesses, sleep apnea, fatty liver steatohepatitis, rather, heart disease, arthritis of the knees, and reflux, 10 to 15%. And then finally, to see actual remission of diabetes, cardiovascular mortality benefit, and heart failure benefit, and others, you need more than 15%. Now this is really beginning to make sense. And that's why I say that obesity treatment is the superwoman of treating metabolic disease, because it defeats all of the bad guys, all the disease, all the metabolic complications that go along with obesity and diabetes can be treated by just treating the obesity. Treating blood sugar, it doesn't get those. It will control your blood sugar, but it's not going to make your lipids better. It's not going to make your sleep apnea better, and on. So let's think about this for a second. If you have obesity, would you sit around and wait to develop diabetes, high blood pressure, heart disease before you could treat those individually? Or would you treat obesity? Would you lose weight and prevent them all? And my guess is that most physicians would choose to lose the weight and never develop these problems. Unfortunately, our prevention paradigm is not completely in place yet. We're getting there, but it is not. But we'll see that the American Diabetes Association has taken some very important steps forward in trying to prevent these diseases. Now, I wanted to mention in the last few minutes a very important trial which was published in December, and that's the SELECT trial. The SELECT trial was a randomized controlled trial of semaglutide 2.4 milligrams in people with obesity and cardiovascular disease. So they had to have had a heart attack or a stroke. And they were followed for an average of 4 years, as long as 5 years. 17,600 patients, 8,800 in each group, 800 on the semaglutide, 8,800 on the placebo. The mean weight loss was only 8.5%, less than we typically see. One reason is that in trials like this, there's no weight management program. It's just take the medicine or not. Things are done to try to keep people in a trial, but there is no specific weight management program. So, and also this is not maybe the typical group of patients who would be in a clinical trial that we run. So the weight loss was clearly less than we usually see. If you look at the clinical trials of semaglutide 2.4, the average weight loss is twice that, 16, 17%. But the important point is that the results were very clear. What it showed was that SEMA reduced death from any cause, heart attack, and stroke by 20%. That was the primary outcome. Heart attack, events of heart attack, stroke, and cardiovascular mortality reduced 20%. That's on the order of lipid-lowering treatment or blood pressure-lowering treatments. It's in the same ballpark. And I'll point out that these people were already being treated by their doctors for their blood pressure and cholesterol and whatever else the doctor thought should be treated. So this benefit is over and above that benefit. But there were some other important findings. There was a reduction in worsening heart failure, worsening kidney failure, blood sugar abnormalities occurring, and the risk of type 2 diabetes. And I'm going to show you this in a little more detail. The risk of developing type 2 diabetes over the course of the trial was reduced 73%. 73%. I mean, that's a pretty big number. And blood pressure and triglycerides, and the list could go on and on. So I think that as a result of this, it's going to be increasingly difficult as we see the health benefits of losing this kind of weight. It's going to be difficult for an insurer to say, oh, we're not going to pay for this. There's no benefit. It's just cosmetic. You know, things like that, which they have said in the past. I personally believe it's going to be harder. And as evidence of that, Medicare has already approved semaglutide 2.4 for the treatment of cardiovascular disease in people with obesity. So if you have Medicare and you have coronary artery disease, you had a stroke, you have obesity, they will cover the use of semaglutide 2.4 milligrams. Really a big advance. Now, I wanted to point out from the SELECT trial the diabetes prevention results, since that's what we're talking about. Remember that these drugs, I totally get that this is also that semaglutide was initially improved as a diabetes treatment, and now it's an obesity treatment. In a different world, it would have gone the other way around. It would have been first approved as an obesity treatment, and then we would have noticed the glucose lowering effects, but that's how things are in the world right now. So I totally get that these drugs lower blood sugar. But look at this, the risk of developing diabetes, meaning a hemoglobin A1C of greater than 6.5% in people who had an A1C below that, was reduced by 73%. And the number of people you need to treat to prevent one case of diabetes was just 12, just 12. So for people in this study with heart disease, you treat 12 of them, and one case, you will prevent one case of type 2 diabetes. Just below that is prevention of the risk of pre-diabetes. And that's hemoglobin A1C greater than 5.7% among those who had a baseline that was less than that. And that was reduced 67%. And the number needed to treat there was only 3.4. I mean, that's unbelievable. That is unbelievable. If you, just to go back to these numbers for a second, the number, so 12% of the people in this trial of 17,000 people, of 8,800 in the placebo group, right? So 12% of them developed type 2 diabetes over the course of the trial, over the 4 years, right? So 8,800 people, 12% developed it. That's like 1,000 people. On the other hand, in the treated group, only 3.5% developed type 2 diabetes. So it was 1,060 people in the placebo group versus only 306 people in the treated group. I mean, that's a huge number. And that tells us that, you know, there's something going on here with these medicines and diabetes prevention. If you could prevent 73% of people from developing diabetes over a 5-year period of time, I think that would be a really, really good thing. And there were other health benefits as well. There were benefits in heart failure, chronic kidney disease, fewer people hospitalized, fewer procedures, and the list goes on and on. And as far as safety in this trial, again, the biggest trial we've seen with one of these drugs, there were no cases of medullary thyroid cancer, which is a complication that we're concerned about. There was no pancreatic cancer. There was no difference in the incidence of pancreatitis in the two groups. It was exactly the same. In fact, there were a few more cases in the placebo group. So I think what we're seeing is that medicines like this are turning out to be maybe a little safer than we thought and having more benefit than we thought. I just wanted to give you an example of the kind of patient who we see. This is Scott, our patient for over 10 years. When he was young, he was nicknamed Bones. He was so skinny. At the age of 30, he began putting on weight. So by the time he was 56, he was 265 pounds, and he described himself as miserable. He's the general manager of Zabar's, a deli in New York, and he had relentless cravings for food, and he would eat large amounts of the baked goods that they had at his place of work. And when he first came in, he said, "I eat for a living and I have no intention of doing anything you tell me to do." His medicines, when he first came in, he was taking a TZD, a thiazolidinedione, and a sulfonylurea for control of his diabetes. And what we did was we changed his diabetes regimen. I told him, you're eating, I know this is going to be important. I asked him just to eat a yogurt for breakfast. Just eat a yogurt for breakfast, and then whatever you're going to eat, I know you're going to eat it, so just do whatever. So we changed his diabetes medicines, and then later on added anti-obesity medicines. And if you ask him how he lost weight, he will tell you, "I have no idea because I did not change anything." And here's his weight curve. And there he is in Zabar's with some of the bagels. He was saying when people challenged Los Angeles bagels versus New York bagels, he came out with his bagels and said, Los Angeles bagels? Everybody knows New York bagels are better. So this is actually after he had lost some weight. I told you he started at 265. This curve starts at 236 pounds. His BMI was 37. So we switched from pioglitazone to canagliflozin, an SGLT2 inhibitor, which we know is associated with some weight loss. We added bupropion because he had a lot of sweet cravings. We added liraglutide as we went along because, again, he was hungrier, and we were still looking to get better control of his blood sugar. His A1C when he first came in was 8.2, by the way, so he was under poor control despite being on 2 medications. He was on bupropion. We switched him to bupropion naltrexone, which works better for weight loss than bupropion alone. He stabilized at a weight of about 185 pounds. So he lost about 50 pounds, but then started regaining gradually. We tried adding topiramate, which we know can affect binge eating behavior, but eventually we discontinued it and we changed the liraglutide to semaglutide. And what we see is significantly greater weight loss. So it's clear from this example, in my opinion, semaglutide is more potent than the liraglutide at both reducing weight as well as glucose. He had a mild MI and 2 vessel stents. As we went along, we changed to empagliflozin from canagliflozin, and then eventually we changed from semaglutide to tirzepatide, and he actually lost some more weight, and he currently weighs about 168 pounds. So about 100 pounds from the very beginning. And this is what you can achieve with patients like this. His A1C, by the way, is 5.6. So went from 8.2 to 5.6. So we look at this as weight-centric management of his type 2 diabetes. We're not saying that weight is the only thing, but by looking at this from the weight perspective, from the obesity perspective, we think we can treat people a lot better. So he lost 25% of his body weight at that point in time, and his A1C was down to 5.7. So the idea of managing people's weight as part of their diabetes, to my knowledge, this is the first mention in the medical literature, was 2012. And again, the idea of treating weight, treating diabetes as well as its complications, was not popular as recently as 12 years ago. Now, a lot of people say, oh yeah, this is totally obvious. It wasn't. And I want to point out that Dr. Eagle was the first author on this, out there in front, recognizing the very, very important value of treating weight. And now there's been a big change. These are the most recent guidelines from the Diabetes Association. These are the standards of care for this year, and they've changed a lot. So here's one change, that metformin has the strongest evidence base for diabetes prevention. So even though it's not approved yet for diabetes prevention, the American Diabetes Association mentions that it has a strong evidence base to prevent diabetes. That's a really good thing, because we see people with prediabetes all the time, and their doctors won't give them a medicine as simple as metformin because it's not approved for that by the FDA. But now maybe with the ADA supporting this idea, which I believe this is, we are seeing that, maybe we can begin preventing diabetes from developing. Who should be considered for metformin therapy? And we have a whole list of people here, those who have a BMI greater than 35, those with a higher fasting plasma glucose greater than 110, those with a higher A1C greater than 6, and those with a history of gestational diabetes, because we know they're at risk for developing diabetes. I think this is very reasonable. We're more aggressive, but this is very reasonable. And then what parameters should be monitored? Vitamin B12, because we know that in taking metformin, your B12 can get lower. And there's an entire section on obesity and weight management for the prevention and treatment of type 2 diabetes. And again, I told you that back in the day, this was not standard of care. And I'm not going to go through the details of this. They call it the person-centered approach. Again, the idea being that if someone has obesity, then you need to manage the obesity in addition to managing the diabetes. And that's going to manage all of the obesity-related complications. So once again, Dr. Eagle was right out in front. So in conclusion, I just wanted to congratulate Dr. Eagle on his award. I think it's it's a terrific thing. He deserves it for his pioneering work. I'll tell some more about it tomorrow at the event. But I'm very thankful that I was invited to speak today, and I'm happy to answer any questions that you may have. Thank you very much.
Thank you, Dr. Aronne. That was really, really wonderful. So Dr. Aronne and I'll chat for a little bit while people are putting in questions if they have any. So feel free to put questions in the Q&A. But I will go ahead and get started and ask you a couple of follow-ups. So first of all, thank you. That was truly incredible. It's amazing, amazing, amazing to hear kind of the history of what's happened over the last few decades and where we are now. And it's just so exciting for us as obesity medicine physicians to be able to help our patients in ways that we just could not before. And the gratitude, patients used to be so grateful, but now it's like, the number of patients we have who have lost such an incredibly significant amount of their weight and have really, reduced their risk of diabetes, control their diabetes, have improved, resolved, reduced the risk of other comorbidities. It is truly, why we all love what we do so, so, so much. So thank you for that fabulous presentation. Talking about the weight-centric diabetes approach, it is really exciting to see where we've come in the field of diabetes, from tons of insulin, sulfonylureas, to all of the better medications we have now. And we are seeing the guidelines sort of catch up with, all of the science in terms of how we should be, treating diabetes differently. Do you anticipate any kind of further changes, or what do you think the future of, the newer medications coming to market? What is the future here in terms of, treating obesity to treat diabetes, what we can expect coming down the pipe, and how that's going to affect guidelines?
Sure. Another paper that we wrote a number of years ago was about how we thought obesity is the new hypertension, so that the treatment paradigm for obesity is going to resemble that of hypertension. In hypertension, there are 10 therapeutic categories of drug, and there are more than 100 drugs. I don't think we're going to have that many, but there are more than 50 currently in development. And I think that we are going to be better able to target different forms of obesity through diagnostic testing and treat people more effectively, so they'll have fewer side effects and greater levels of efficacy. I think that's one trend. I think another trend is going to be treating people earlier. Instead of waiting until they have a severe case of obesity, it may be using a lower dose of medicine earlier in the process, so they never get to that point. I think those are some of the trends that we're going to be seeing as time goes on.
Mm-hmm. Absolutely. Really exciting. The more tools we can get in our armamentarium, the better. There are always so many questions whenever we give talks to any kind of audience. Such a hot topic right now is this idea of kind of deprescribing, or, what to do once people, have lost weight and now they're in the phase of weight maintenance. We know that obesity is a chronic disease, but what are your thoughts on this idea of getting people off GLP-1s, deprescribing, de-escalating care?
So what we're finding is that some people don't need the dose that they're on to lose weight. So we've had a number of cases where in fact, I just saw somebody this morning where she has lost a significant amount of weight. She's got a BMI of 24, and we're in the process of reducing the dose every month or two because her weight is remaining stable. So we're trying to see how little she can take to maintain her weight. Most people take it less frequently. It's just because of the complexity of prescribing lower doses. Eventually, I think that the insurance companies will catch up to this. But for now, we might give it every 10 days, every 2 weeks. But what we would really like to be doing is going from, let's say, if someone's getting semaglutide 2.4, cutting back to 1.7. But I definitely think that there are a significant number of people who can take lower doses and may be able to be off the medicine for a period of time. But there's no question that they will need this intermittently, at least intermittently.
Thank you. Such a hot question right now. One question, how important are neurobehavioral digital therapies like software as therapy in preventing, treating, and managing obesity and diabetes? What is the role of digital therapeutics as companions to therapy and meds such as GLP-1s and bariatric surgery?
I think that digital therapies are going to turn out to be extremely valuable. One of the key reasons is there aren't that many people to treat obesity. I mean, if you look at the number of people who have been credentialed in obesity medicine, it's a very small number, thousands, just over 5,000 compared to the millions of people with obesity. The numbers just don't balance out. So I think that both specialists being able to see more people, extending the range of specialists, I think that that's one area where digital therapies can be critical in streamlining the care, but also for primary care physicians to be able to treat their own patients with digital therapies that have recommendations for prescribing. What I get asked this all day long. What medicine should I give this patient? Should I give them this or this? They can't afford that. It's not covered by insurance. Now what should I do? There are a million questions that can be built into digital therapies. So I think that those are two areas to accommodate this enormous demand where digital therapies are going to play a very, very important role.
Yes, totally agree. Another question, do you envision lifestyle programs being required in the future as standard of care in a structure of combo therapy like GLP-1 plus lifestyle? This could help payers and employers more widely adopt them.
Right. I've already seen this. So we have to do prior authorizations all day long. And I saw a prior authorization that asked if the patient was enrolled in a behavioral program. And so I think that the insurance companies recognize this, that the best results are going to occur when they do it. So, it's been what we've seen in some of the studies is that you can't get weight loss over and above the maximum weight loss with these medicines if you add a very intensive behavioral intervention. But I think that from looking at the SELECT trial where there was no behavioral intervention, that having a behavioral intervention could enhance the minimal result. So that makes sense. So if you don't do anything, I think you're going to lose less than you could lose if you add the behavioral program. And I think if they're paying for the medicine, they deserve to get the best result possible. So I think we're going to see more of that. And it may be, how do you make it mandatory? I don't know how, but I think they're going to want to see that.
Yes, it's definitely part of prior auths and, part of what we do, because we're not just trying to help people lose weight, we're trying to improve health outcomes. And so, while the lifestyle component may contribute less to, the weight loss, it contributes so much to the health outcomes. And especially, when people are eating less, optimizing what they're eating is tremendously, tremendously important. So, we get this question all the time, like, what about, are dietitians as important now? I actually just gave a talk to the Academy of Nutrition and Dietetics about, how nutrition right now and the role of nutritionists and dietitians is so much more important to really complement what we're doing and really help people optimize their eating and tolerate the medication. So, so important. Question about psychotherapy. What about the role of psychotherapy in weight loss? How important is this?
Look, I just want to say one word about the dietitians. The role of the dietitian has changed dramatically from in the past, it was sort of being a cheerleader to try to reduce calories in the face of what people felt, which is they were hungry, and the dietitians and us, we would be telling them, gee, stick with your diet and eat less. And now it's trying to be sure that they're getting good quality diet, that they're eating high quality food, a lot of vegetables, a lot of healthy proteins in order to get the best nutrition. Those are the kinds of things we're recommending. Again, some of these medicines can dramatically reduce appetite. And, we think that people need to be consuming foods that are consistent with really good health. And that isn't always the case. So that has now become the role of the dietitian. So there was a question about psychotherapy and weight loss. I think that some people can benefit from that. There has been concern that when you take away the crutch that some people have in the form of eating food, what's going to happen psychologically to them. I can't say that I've seen any issues with that, but we joke around that in Los Angeles, everyone has a trainer, and in New York, everyone's got a psychotherapist or a psychiatrist. So the people we see all tend to have psychiatric support of one form or another. So I do think that there is a role for that in the management of patients. Does everybody need it? No. But are there some people who need it? Yes, I think it would be very helpful.
Yeah, and it brings up the point that everybody's treatment looks totally different. Obesity isn't just one, straightforward condition. When we evaluate patients, we really figure out every factor that's going on. And for some people, working with a psychotherapist from the very beginning is critical, while for others, they might not ever need to. So we really, really, really need to individualize our treatment. I'm not surprised there's another question about de-escalating. This one is, at what point during treatment do you determine when it's appropriate for dose reduction of therapy or de-escalation? And then do you re-increase doses again if you notice a rebound effect upon de-escalation?
So I'll answer the second part first. We would absolutely increase the medication dose if someone started to regain weight. That is something that we would do. And, we tell patients that don't worry, we're not taking this away from you. It's not like we're going to say, sorry, that's it. You're not going to get it again. It's important for people to know that, because they're petrified that, uh-oh, here it comes again. This has happened every time I stop the medicine, I'm going to regain the weight, or, I go on the diet and then eventually I regain it all. They have to know that they're going to have access to the medicine if they need it. There are a couple of scenarios. If someone is in at a desired weight, it's basically shared decision making with the patient. That's how we'll do it. We'll get them to agree to whatever plan we have to either take it less frequently or reduce the dose for each injection, or oral. If it's an oral, we'll do it that way. Some people have side effects late in the game. So they're taking it, and for some reason, I don't know if they become more sensitive to the medicine, but we have seen this a couple of times where people start having more nausea, a year later after they've lost a lot of weight. In that case, we would use that as a reason to cut back on the dose, even if they haven't gotten to their desired weight.
Yeah, that's such a good point. I know. I've been seeing more cases of that recently too, where people have been on the same thing for years and years and years, and then out of nowhere, something happens, and we can't pinpoint, what it is. So definitely something we need
So
to be.
what we would do in that situation is cut back the dose and see how they do. I can't tell you that I've done a study of it. My belief is that they will continue to maintain their lost weight.
Yeah. Okay, well, I think that we covered every single question. So thank you so much to the audience for your participation and for your wonderful, wonderful questions. And thank you to Dr. Roney for an absolutely incredible talk. I'm glad this is being recorded. Hopefully it will be available for others to watch going forward. And thank you for the ADA for sponsoring this. It is such an honor for us to be involved in this research week. And we look forward to ongoing events.